some wonderful today. And my name is Heather Hancock, for any of you who don't know me, and I am one of the co-chairs of this community of practice. We do have interpretation available today. So if you would like to, please click on the interpretation button at the bottom of your screen and you can select your preferred language. And I just want to briefly introduce our co-chairs today. I've already introduced myself, but we also have Manya Dotson, Sige Playa, and Amy, excuse me, Dickerson, all from Jhpiego Momentum and Country Global Leadership. Our objectives for today's meeting are to discuss the current state of women's leadership in global health, share strategies to address the gendered leadership gap in health systems, and efforts to increase women's health leadership. And we'll start out today with a few announcements, and then we'll have a couple of presentations where we will hear about the current state of women's leadership in global health, and then we'll have a Q&A session. And then we will have a panel of 3 wonderful women leaders in global health who will share some of their stories and their experiences. And then we'll have a final presentation about some of the programmatic efforts to increase women's leadership in global health. Finally, we'll have a brief group discussion to synthesize the things that we have learned, and we will wrap up. So just a few announcements to get us started. We wanted everyone to know, because several people have been involved in the provider behavior ecosystem work, that we now have a new brief that is on applying a provider behavior ecosystem lens to maternal, newborn, and child health. If you recall, this was something that was initially developed for family planning and reproductive health, so it's exciting to see it being applied to some different health areas. And Allison will be pasting the link to the brief in the chat. And then we also have Breakthrough Action did a literature review to understand better the factors that influence community health worker behavior. And this is, again, building off of the provider behavior ecosystem, but looking at it from a community health worker lens. So again, Allison will paste the link there for you as well. And then we have an upcoming webinar on leveraging SBC to strengthen health systems, which we did already send out to the community of practice. So you should have gotten an email about that. But we also have the link to register for that webinar for those who are interested, which is next week. And then I also wanted to share that with the closing of Breakthrough Action in the next few months, we will be transitioning the co-chair responsibilities for SBC to the Inspire Social and Behavior Change activity. And Hope Hempstone will be the lead. I know many of you know Hope. And so I just wanted to turn it over to Hope, and she will just explain a little bit about the transition to the co-chair. Hope, are you there?
I am here, and hopefully you can see me. Thanks, Heather. So I know many of you, but for those I don't, my name is Hope Hempstone, and I am the Senior RMNCH Advisor for Inspire SBC. I'm just going to take a couple of minutes to introduce the project. But I will try not to take too much time because we have an exciting agenda today. So Inspire is a newly awarded USAID central mechanism that's focused on designing, implementing, and promoting. I'm going to ask somebody to mute. There's some background noise. Thank you. We're focused on designing, implementing, and promoting evidence-based, locally led SBC across the health sector, as well as, to a lesser extent, in non-health sectors. And we anticipate that much of our work will focus on RMNCH, malaria, and global health security. We're primed by FHI 360 in partnership with Save the Children, the African Society for SBC, UKES, FRAME, and Data Science Nigeria. And we are also very lucky and excited to have 4 regional SBC partners that will be heavily involved in our work at the country and regional levels. And those are IPE Global, which is based out of India, CBCC, which is based out of Kenya, NOWEDI, which is based out of Mozambique, and ONG RACE, which is based out of Senegal. Again, a couple of areas in which you can expect particular emphasis from us. Data use and technology, including machine learning and AI. I know an area of great interest to all of us working in in SBC and beyond, private sector engagement and resource mobilization, improved quality of community level SBC, including in conflict affected and fragile settings, and finally, of greatest relevance to this group, integration of SBC in service delivery and health system strengthening, with an expanded focus on community-based providers and CHWs, as well as health systems actors other than providers. So as Heather said, we will be serving as a co-coordinator for this group effective in 2025. And we look forward to working closely with JPICO, CCP, and the many other organizations that are active in this community. Before I pass back to Heather, I just want to acknowledge the incredible work that Breakthrough Action has done in launching and sustaining this community of practice. They are true pioneers in applying SBC and service delivery, and I know that FHI 360 and all of us in this community have benefited tremendously from their leadership. So this is not goodbye to them. We know that they will continue to be central to this work, but I want to gratefully acknowledge everything they've done to date and say that we look forward to carrying on their legacy. Back to you, Heather.
Thank you so much, Hope. And yeah, we're really, really happy to have been coordinating this community of practice. It's been a really great source of learning and coordination between partners. So thank you so much. And just to emphasize, as Hope said, JPICO will continue to co-chair as the service delivery lead, alongside Inspire SBC. So we will be sending out emails with a little bit more detail about that. And this is all building on the sustainability and transition plan that you all helped to contribute to over the last year. So I want to move on to the exciting portion of our agenda, where we will start with a couple of presentations. And I would like to first introduce Shubha Nagesh, who is an advocacy advisor in the global health for women in global health. And she will be sharing the state of women in leadership in health. So welcome, Shubha. Over to you.
Thanks, Heather. Can we have the slide deck, please?
Can you see it okay, Shubha?
I can't see the slide deck yet.
Oh, can others see the slide deck?
Yeah, we can see it.
Yes.
Okay.
I wonder if Shubha needs to disconnect and reconnect.
Okay.
Shubha, were you able to see the slides before?
No.
No. Let me stop and reshare and make sure that you can see it. Hold on one moment. Can you see them now, Shubha?
Yes, I can see it now. Thank you. Sorry about that.
Okay, no problem.
Okay, so good evening, good afternoon, good morning. My name is Shubha Nagesh. I have been with Women in Global Health for the last 3.5 years. And in my current role, I serve as the advocacy advisor for global health. So this report was undertaken by Women in Global Health as research on the state of women's leadership and global health to assess the pace of change at the global level, the impact of the pandemic, and also to inform our own recommendations with country experiences which were based out of India, Kenya, and Nigeria. Next slide, please. Next slide, please. Okay, so basically, the key finding was that progress has stalled. So even in 2018, women constituted about 70% of the health workers and held only 25% of the leadership roles. And in 2023, when this report was released, the main finding was that women continued to still hold 70% of the health worker roles and just had 25% of leadership roles again. Next slide, please. So this was really a synopsis of what happened between 2018 and 2022. So while Fortune 500 healthcare companies actually were led by women, increased from 5% to 12%, but what we saw was the number of female ministers in health had actually reduced from 31% to 25%. And at the World Health Assembly, delegations led by women had actually fallen from 27% to 23%. Next slide, please. So when we looked at the national state of women's leadership in health, in Kenya, there is a highly patriarchal culture, but women held only 42% of the positions at the mid-level and a mere 40% of the top-level leadership positions in the health sector. In India, it was worse, with women averaging about 28% of the leadership roles across national health organizations. But averages, of course, were misleading because some of the organizations almost had no women at the leadership positions at all. And in Nigeria, we had about 33% of the leadership roles in health organizations, but only 5 out of 30 national ministers of commissioners were women, and only 1 out of 28 of federal centers are women. Next slide, please. So women actually lost ground in health leadership during COVID-19, and the pandemic actually revealed the fragility of women's position in global health leadership. At the 2022 WHO's executive board meeting, which happened in January, only 6% of the executive board members were women, and this was down all the way from 32% in 2020. So the Women in Global Health study in 2020 showed that 85% of the 115 national COVID-19 task forces had majority male membership. Next slide, please. Some groups of women, as shown in the report, were most excluded from health leadership. In some of the low-income countries, low levels of education and literacy restrict the level at which some women can enter the health workforce, and therefore prevents them from progressing along the leadership journey. And despite their critical roles in delivering primary health care and being community leaders, the women community health workers were typically excluded from formal leadership opportunities. Next slide, please. Across contexts and cultures, however, we found that women experience common challenges in accessing leadership in health. So women in global health research in India, Kenya, and Nigeria confirmed that there were common challenges related to leadership for women who worked across the health sector. And qualitative data from over 100 respondents confirms action needed at all levels to change powerful gender norms and biases that discriminate against women, not just in their homes, but also in workplaces and largely in societies. Next slide, please. So gender norms and roles limit women's participation at work and in leadership. This was one of the key themes that emerged. And here are 3 quotes from Kenya, India, and Nigeria. So a doctor in India said that since childhood, I have only heard this as a gospel truth. Women's primary job is to take care of the household. It is difficult to keep challenging this notion, even internally, when everyone around you keeps saying this. When I got married, my mother-in-law very explicitly told me that my job is to serve my husband and my future son. Another doctor from Nigeria said, you know, our cultural environment does not really support women as self-starters. We are always taught to follow instead of lead, and it takes a lot to overcome that. A lecturer from Kenya said, if you don't have a spouse who is supportive, you will stop working. We have had women who stopped working because the spouse said, no, you can't go there, you can't go to work. Next slide, please. The second finding was that women experience discrimination linked to the motherhood penalty. So a doctor in Kenya said, so you turn down a lot of opportunities because of pregnancy and because of nurturing, nursing the baby. By the time you come back, you find that things have moved on. It takes a lot of effort to come back. Another doctor from Nigeria said, some things are really critical for us women. I know 2 women who have postpartum depression, but nobody seems to understand them. And a nurse in India said, This time, the post-delivery was particularly traumatic for me. I was torn between caring for my child and thoughts about my precarious position at work. Next slide, please. And the third theme was that gender stereotypes around leadership not just deter but also penalize women. So a clinical officer from Kenya shared that the women you find are the ones being told to serve tea because it's what the society is used to. Even when a woman is in a leadership position, they're told they cannot speak too much, you cannot be assertive just because of the society. Another doctor in India said that I have been called emotional several times, which has forced me to step back and not put myself forward in leadership positions. A professor from India also shared that women often feel excluded and left out in their workplace due to certain unique qualities they possess. It tends to diminish her voice and discourages her. Next slide, please. So governments have made global commitments to gender equality in decision making, but the report found that these commitments can only drive change in countries when they're actually implemented. And this research confirmed that global commitments are not actually being implemented fast enough or with enough accountability at the national levels. So in Kenya, the constitution decrees that not more than 2/3 of the members of the elective public bodies should be of the same gender, yet this is not a reality. Beautiful policies, but very poor implementation strategies. Labor laws in Nigeria allow for a 3-month maternity leave, but it is not universally enforced. If you're a nurse and you have a baby, the government will not provide anything for you. It is sad. India has a Prevention of Sexual Harassment Act to address workplace sexual harassment, but it lacks teeth. I went to my supervisor with my complaint of sexual harassment. Not only did he overlook my complaints, but I was harassed more to such an extent by the administration that I had to ultimately quit my job at the hospital. Next slide, please. Gender equal leadership at the national level will feed female talent into global health leadership. So for as long as societal gender barriers are not addressed and systemic bias against women continues, men will continue to be the vast majority of health leaders at the national level and will also continue to dominate global health decision-making. Next slide, please. Women continue to shape leadership in health, but not all of them are recognized and rewarded. So one of the respondents who was a head of a department in India said, I think to be a leader, one should be able to empathize and be approachable. Women are good leaders, in my opinion, because they are usually emotional and they connect with people sensitively. Another doctor from India shared that leadership is about setting an example and leading with care. You have to set an example and become a guiding light and source of strength for future generations of women. I think of it both as a personal and a political goal. A nurse from Kenya shared that if you are a leader, you should be able to mentor others who are around you so that they can either come to the same level that you're in or even surpass that level. And leadership for me means innovation also. You should be able to come up with new ideas. Next slide, please. So these were some of the findings from the report, and now we'll just share a few recommendations from the report. Enable diverse women to lead. So create tailored leadership opportunities for women from marginalized backgrounds. The second is to fast-track actions to redress gender inequality in global health leadership. So all women shortlists, quotas, rotational leadership, interim measures, etc. The third is to increase visibility for women in health. So create lists, databases, and platforms, all of which strive to raise the profiles of women in health. Next slide, please. The fourth point, the recommendation the report makes is to mobilize men to lean out and step up as allies and to end the male bonus syndrome. So normalize paternity leave and other family-friendly policies that tend to shift gender norms to share the burden of care work equally between men and women. The fifth recommendation is to end the default man bias. So prioritize the implementation and the accountability for policies that support women's lives, safe spaces for lactating mothers, recognizing that the default women worker, unlike the default man, may need support for breastfeeding, etc. And the sixth recommendation is to support women's movements to accelerate collective action. So targeted funding in support of women's organizations to support the establishment of political networks for women and allies. Next slide, please. But broadly, what this report really recommends is to deepen our understanding and also to strengthen the evidence base for policy with more research and data. So how do we generate more disaggregated data to understand the way different disadvantages intersect with sex and gender identity? How do we do targeted research with men to understand why bias persists and how to mobilize allyship? And finally, how do we continue to build the evidence base on how sexual exploitation, abuse, and harassment adversely impacts women and leadership? So all future research should take an intersectional approach, and it's really about fixing systemic bias and not at all about fixing women. Next slide, please. So that was in brief the report, but very quickly before I end my presentation, we want to share some information about one of the initiatives we launched a couple of years ago. It's called the Gender Equal Health and Care Workforce Initiative. Next slide, please. So there are 4 pillars of this initiative which aims to drive action in the health and care sector. The first is to increase the proportion of women in health and care leadership roles. The second is to recognize the value of unpaid health and care work and the importance of equal pay in the health and social care sectors. The third pillar is about protecting women in health and care against sexual harassment and violence at work. And the final pillar is to ensure safe and decent working conditions for all health workers everywhere. Next slide, please. So since its inception, this initiative has actually garnered commitments from many different governments, including Congo, Brazil, France, Ethiopia, Argentina, Chile, Costa Rica, Fiji, Liberia, Malawi, the United States, the United Mexican States, the Republic of Guinea-Bissau, Islamic Republic of Pakistan, etc. And we also thank a lot of international organizations who have pledged to uphold their commitments under the Gender Equal Health and Care Workforce Initiative. So these are some of the organizations who have become signatories to this initiative. It is a work in progress, and we continue to have more signatories to this commitment and continue our work on gender equal healthcare workforce. Next slide, please. So thank you very much. I have to leave this meeting, but if you have any queries about this report or if you would like more information, you can find the report on our website, or you could email me on shubha.nagesh@womeninglobalhealth.org. Thank you very much for your time.
Thank you so much, Shubha. That was very interesting and sobering to hear some of the statistics, but really great to see some of the work that you all are doing to improve that status. So thank you so much. And as Shubha said, if you have questions, you're also welcome to put them in the chat and we can share them with her later and share back during our meeting notes as well. Thanks so much for joining us, Shubha. Our next presentation will be about exploring the impact of women's leadership, and we're really happy to welcome Anna Kalbarczyk, who is the Assistant Director at the Johns Hopkins Center for Global Health. Welcome, Anna. Over to you.
Great, thanks so much, Heather, and thank you all for being here. I'm joined today also by Dr. Anju Malhotra, who is faculty at Johns Hopkins and also seconded to the Global Financing Facility. And she'll be helping me talk a little bit about the framing for why GFF has been interested in exploring the impact of women's leadership. But briefly, to introduce this project, we'll be talking about a research study that's co-funded by the Global Financing Facility and Gavi, the Vaccine Alliance, on exploring the impact of women's leadership in ARM and CHN and immunization, particularly across sub-Saharan Africa. Next slide, please. We ground this research in the recognition that women face many barriers to leadership globally, and that these have been very well documented in the literature. And so part of our goal was to move beyond these barriers, recognizing that they exist and recognizing that women's leadership might be in response to some of these barriers as well. But knowing that these barriers have been documented, we wanted to really try to document the unique impact that women leaders have been having in these spaces, while also dealing with these challenges. And some of these have been previously explored and described, but include gender bias and discrimination, lack of representation, work-life balance challenges, including care expectations, which were so well outlined in the previous presentation, limited access to networks and to mentorship, cultural norms and expectations around women's roles in the house and also at work, resource inequities and challenges receiving funding, two effects known as the glass ceiling and the glass cliff, which are essentially where women are unable to reach leadership roles as the ceiling, and the glass cliff is where women are placed into precarious leadership roles, often because they are either perceived as being able to fix something that is broken, or because no other leadership roles are available to them. And the invisibility of women's contributions, some of which can be seen around teamwork, or just around things that aren't necessarily fostered as things that are promotable within organizations, sexual harassment, and the recognition that much of women's work is unrewarded. Next. Anju, can I turn it over to you to walk us through this slide and really ground us in GFF's investment?
Sure. Can you see me?
Yep, you looking great.
Great. Hello, everybody. Nice to be here and nice to join Anna's presentation, especially after Shubha's sobering remarks and the study. And it is because we know that the situation is not improving that the Global Financing Facility, which is one of the 3 global health initiatives for funding, along with Gavi and the Global Fund, that has been established and supports governments to fund their health efforts. The Global Financing Facility was established in 2015, and it's housed at the World Bank. And it was created specifically to improve health systems with the aim of improving ARM and CHN outcomes. So outcomes that are actually more directly affecting women and girls than even what Gavi and the Global Fund supports. And the Global Financing Facility has a strategy in which gender equality and country leadership are part of the strategic goals, which is one of the reasons why this partnership with Hopkins was established 3 years ago, to really advance measurement and investments in gender equality in countries that GFF supports. There are 36 countries that GFF supports with leveraging World Bank financing and providing additional financing to governments to move forward their health system reforms. And most of these countries are in Africa, which is why this particular study was focused on Africa, but it obviously has implications elsewhere. GFF also supports countries in Asia and in Latin America. So unfortunately for us, Gavi, the Vaccine Alliance, had a similar interest. So this particular study has been co-funded by GFF and Gavi, and we hope that the implications will inform the kind of financing and technical support that both organizations can provide countries in reforming their health systems. Back to you, Anna.
Thank you so much, Anju. Next slide, please. So our study aims were to identify women leaders' influence and impact within these two fields across sub-Saharan Africa, and identify areas for investment in women leaders within these fields as well. Next. Within the study, we had to be very clear about who we considered to be a woman leader, since we know that leadership can occur at all levels and in different ways. But we defined women leadership as women who occupy a position that gives them influence and power over identifying priorities, providing strategic direction, allocating resources, and decision making within these fields at either the sub-regional, regional, national, or continental level. Next. We conducted a desk review, a cross-country survey and social network analysis among both men and women leaders, and a series of key informant interviews with women leaders as well. And it's results from these three arms of the study that I'll be talking about today. We also conducted 3 in-depth case studies in Ethiopia, Madagascar, and Zambia, which we won't be sharing the results of today, but those will be disseminated in the coming months. Next. In our literature review, we identified 137 articles and identified 6 areas of impact of women leaders. Across these articles, there were largely mixed results, though largely leaning positive, which you can see from the heat map on the slide. And results were particularly positive when modified by other factors. So, for example, if you had women leaders with more education or with more experience, then you were able to see more positive results or areas of impact. These 6 buckets or 6 areas of impact included financial performance, risk and stability, engagement with ethical initiatives, innovation, and this largely could have been innovation in technology or embrace of technology or of new ideas, areas of impact in health, organizational culture and climate, and influence on other women's careers and aspirations. And where you see articles that might be over 100%, this was because they were some reported both positive and negative outcomes. Again, likely exploring modifications or moderations by things like education or experience, or also critical mass. The more women that you add to the pot, the difference the impact can be. The literature found that women leaders' success cannot be separated from their context and their environment. So we saw places where women were experiencing more stigma or bias within their organizations, were having more difficulties achieving those impacts, which is not surprising given the barriers that we outlined on the first slide, because unsupportive environments can affect the extent to which women leaders have an impact. Next slide. This is an overview of our survey respondents. And so again, we were focused in sub-Saharan Africa and received majority representation from respondents in Central Africa, followed by East, West, and then Southern Africa. We had a fairly even split between men and women respondents. And we looked at respondents as well who were in government, non-governmental organizations, and then a larger grouping of other, which could have included research organizations or academia, and other types of organizations, so that there were so many that from an analysis standpoint, we did need to group them. Next. We so far have conducted, this number's been updated, about 35 interviews have been completed and analyzed, and we're looking to complete another 5 to 10 with women leaders. And this is just demographic information, trying to capture who we've been speaking to across these different fields, the age ranges that they represent, and education level as well. Next. This slide represents a preliminary pathway of what we've been seeing across these different streams of work, across the desk review, the survey, and the key informant interviews, to map the unique types of influence and influential processes that women leaders are using to achieve intermediate outcomes and ultimately health outcomes and impacts. We are not implying causation through this work. We can't, but these are displaying the connections that we're seeing through the unique processes that women leaders are using. And so this is an overview of the diagram that is continuing to be iterated and designed, but I'll walk through subsets of this diagram throughout the next part of the presentation. Next slide. As an overview, what we're seeing in terms of influence is that women leaders are conducting their leadership differently to influence these program and policy changes through things like collective leadership, purposeful targeted engagement, strategic engagement, use of identity-derived power, advancing gender integration and mainstreaming, ensuring representation, and an engagement in ethical leadership approaches. Next. The impact that they're having is the prioritization of women-centric or neglected topics within policy and programming, increased access to care, enhanced inclusivity of services tied back to that stakeholder engagement, and improved trust in services, which is leading to increased utilization, women's empowerment within communities, specifically improved health outcomes such as increased vaccine uptake and improved maternal health, and innovation. Next. Here we'll take a look at the first part of that diagram to look at the influence and influential processes and their connections. So again, women leaders are engaging in collective leadership and targeted purposeful stakeholder engagement, which is helping to increase representation of key groups in decision making and the prioritization of neglected topics. Next. So this purposeful targeted engagement is often targeted at decision makers who are critical in this space, but might not be as keen or as engaged in these issues as other women leaders would like them to be. And this has led to the prioritization of neglected topics and women-centric issues in policy and programming. Next. Through collective leadership, women leaders have been able to advocate for health policy development and implementation, even without male leadership support. So where there might be, active non-support or even just, disinterest, women's collective leadership has been able to bring women leaders together to move issues and agendas forward. Next slide. Women leaders' influence has led to more inclusive health policies, services, and programs for the poor children and adolescent girls, which we have been seeing as linked to enhanced trust in services and subsequent utilization. Next. And involving women in program implementation has strengthened women's empowerment and positively influenced health outcomes. Next slide. The second part of the diagram is around identity-derived power, which has enhanced women's access to women-only spaces, increased trust in services, and increased then that service utilization. By ensuring representation, women leaders have been able to increase the number of women in leadership. And through ethical leadership processes such as commitment to DEI and corporate social responsibility, transparency and accountability, and anti-corruption, there's also been enhanced inclusivity of services. I've been given just 1 minute to wrap up, so I'm going to ask if we can just skip through some of the next couple of slides. So I'm skipping through that. And the next one, okay, stop here. What we're seeing in our survey is that patterns between men and women are largely different, though we're seeing some differences, particularly in terms of who's been remaining neutral about impact, which is largely women, versus who might be disagreeing or strongly disagreeing, which is largely men. The type of organization likely influences the responses. where we're seeing women, whether women leaders might have control over something or not. So they might not have control over the pay gap, mentorship, or establishment of women-centric organizations in government. And that's really coming out in the survey data. Next slide. So women leaders are able to leverage unique processes to positively affect RMNCHN and immunization, either despite of or in response to the barriers they face. And here we might highlight ethical leadership, for example, not necessarily saying that women leaders are inherently more ethical, but that they might have to be responding to barriers or increased they might have to be responding to these barriers and therefore engaging in more transparency or accountability, but that's still leading to these unique impacts, whether it's be despite of or in response of these barriers. And women leaders really can't be separated from the contexts in which they work, and societal and organizational norms can help or hinder the extent of women leaders' impact. So thank you so much. I think next slide is a thank you. Thank you for your time, and I look forward to your questions in the chat.
Thank you so much, Anna, and sorry that you had to rush through some of those points, but we look forward to having some Q&A so that we can talk a little bit more about some of those pieces as well. And this is just super interesting to see the kind of impact that women leaders are having in various areas. So thank you for sharing that. We did want to just launch a quick poll after these to get a sense from all of you to see in your own experiences, what factors have you seen influence women's leadership in global health? Both Shubha and Anna have shared some really great examples of what they have seen through their research that impacts women's leadership in global health. But for you all, what have you seen in your own context that influences whether women are in leadership positions and any factors that are influencing that? So go ahead and respond to the poll, and then we'll share the results. We'll take just about another 30 seconds if people want to add any other factors they think of. Okay, I will end the poll now. So final responses in. Oh, it's not showing for some reason. I'm sorry. Can people see the screen? I'm sorry, I was having an issue with this. Are people able to see these results?
Yes, we can.
Okay, thank you. Okay, so we see a few things that, for example, the courage to try new things and support from a partner. That probably could be multiple partners, including intimate partners. Cultural barriers, the sense of agency that people have in politics, strong mentorship from other people. It's kind of what Anna said earlier, it could be from other women leaders or otherwise. Gender norms generally, and other cultural norms, societal barriers, education, networking. So similar to a lot of the things that we've heard from the presentation so far. More gender norms, motherhood and caring for elderly parents. So some of those responsibilities and roles that women have outside of work. Implementation, including adequate resourcing of positive policies, not just the existence of those policies, and things like informal support systems, again, mentors and supervisors, having that sort of support, both from coworkers and family, and an ability to tie leadership to measurable change. So seeing some of that impact that those women leaders can have. So thank you so much for sharing those. And I also see that Erica also was adding a little point here about how in her earlier career days, having an older female supervisor and mentor who took on a larger burden of international travel while Erica had children and breastfed was hugely helpful. So yeah, having those people who are willing to step in and support that so that you can do your work as well is really important. Thank you everyone for sharing that. Whoops. Okay, let me reshare one moment, please. So we would like to just do a Q&A portion, and I know that there are a couple of questions in the chat, but if people would like to add other questions, or you're welcome to raise your hand and we can respond. As we already mentioned, unfortunately, Shubha had to leave, but Anna is still here as well as Anju. So if you have questions that you would like to direct to them, we can take those questions now. But maybe we'll start with a question that was in the chat around the role of community media. And I don't know if you saw anything in your research around what place community radios occupy in promoting female leadership and strengthening their impact on health services. And then a second question as well, if you have seen any examples of successful campaigns where the media played a key role in supporting women leaders.
Yeah, thanks for that question. And this didn't really come up for us. So unfortunately I can't answer either one of those.
No worries, that's okay. If others who are on the call, if you have seen any role of media, particularly community radios, if you have any experiences with that, you're also welcome to share. And any of our panelists who are joining us today, if you've seen that or if you felt that that helped influence your leadership journey, we are happy to hear that as well. Any other questions that people have?
Maybe I could, Heather, just build on that a little bit. I mean, some of the literature in particular that we found was focused on women's political leadership, which could occur, sort of at the more local level. And that influence on other like women's aspirations into leadership roles or into politics, but also that their effect on community health outcomes and programs and policies that were prioritized in those spaces. And so I do wonder if in places where women leaders are maybe newer into politics or their representation hasn't historically been as high, if things like community radio programs might be able to enhance the messaging of those women representatives and of their policies and programs. So it certainly sounds like a great idea. We didn't see any examples of where this happened, but I definitely think in political leadership, this is a place where those kind of tools could be leveraged.
Yes, and certainly I think, we do see generally the effect with social and behavior change of some of those radio campaigns. So I think that could very much be applied to those settings as well. Thinking about how we can encourage the participation of women or change perceptions of women through some of those as well. So, and on, I don't know if you wanted to unmute and share anything that you have heard about in terms of the social media campaigns in West Africa.
Well, I don't have anything much to say about them, just that I observed that there were these, hashtags or whatever. It was a few years ago, and I don't, I have no insights on who organized it, for what purpose or anything, so I'm not sure there's much to say.
Okay. No worries. Thanks for sharing.
I applaud those kinds of things, and I think, especially in that region, I think I get the sense that some of the youth movements also, have a gender transformative component, which I think is positive. So it would be interesting to look into that.
Yeah.
I don't know if there's research looking at those movements, but it's interesting.
Yeah, definitely. Sadia?
I think from we in Nigeria, the cultural norms really played important role in not allowing women to take leadership. So if, for example, the media, the radio, TV, television, they are being used like to enlighten women, to let them know that yes, a woman can be a leader in her house, can be a leader in her place of work, or she can be a leader in a political position. That will really, really give way for women to be leaders.
Yes, definitely. Thanks for
Thank
sharing
you.
that, Nadia. Andrea?
Hi, Heather. And hi, everyone. This is Andrea Ferrand from PSI. I was wondering if during the research or your conversations, you surfaced anything about perimenopause or menopause related to life stage and women's leadership. And, I think there was some themes and focus around parenting and that part of maybe the life stage. And I'm wondering if, shifts to cognitive ability or sort of changing hormones or other things were mentioned or related here. I think that in this moment, as folks, women, particularly globally, are navigating burnout and other types of stress to their cognitive load, while also navigating perimenopause and menopause and those changes that come, which are sort of just typical of that life stage. I'm wondering if there's anything that came up about that, or that's maybe more recent in terms of women's access to qualified providers who can provide evidence-based support for perimenopause and menopause symptoms and things like that.
This is such a fantastic question. No, I think because most of our women were, I mean, yes, in that perimenopause age range, but I don't think it came up as much as reflections on motherhood and having children did. And that I think specifically because we were talking about the field of reproductive and maternal and child health, people were really mostly reflecting on like identity as mother, not necessarily identity as woman in the way that you suggest. But there's also such limited research on like women's identity as women going through the menopause and perimenopause phases. And this is something that our team has been interested in, not necessarily tied to women's leadership, but in other health spaces. And I think you raise a really excellent point about how that can affect not only leadership, but also like perceptions of self in leadership. I think one of the challenges that women often face is the double bind. That double bind between like what is a perception of woman versus what is a perception of leader, right? And that these things, because the historical perception of leader is so historically male or masculine, that, the very nature of a feminine woman can be at odds with that perception of leader. And so how that changes over time, whether you're going through motherhood as woman or going through menopause or perimenopause, I think is certainly something worth exploring and diving back into the interviews to see if it emerges. So thank you so much for raising that point.
Thank you, Anna. And I also wanted to highlight a bit of the discussion that's going on in the chat. Manya was sharing an example of when she was the country director at PSI. And I think it's interesting to see the deliberate nature that people really do need to be thinking about those things ahead of time, that they were really looking at, okay, if we're bringing on some women, then we need to make some accommodations to dealing with maternity leave or young children and allowing them to travel with their children and getting a hotel room that has more space for their nannies to come along. So I think that those are really interesting considerations that people have to be very deliberate about approaching as well.
And Heather, I just want to add to that there's a great case study about quotas in Kenya that really highlights the importance. I mean, the previous speaker talked about quotas, and I'm totally in favor, personally, for their value in what they can achieve, but you saw at the same time that where you had quotas without this very type of institutional support that's being discussed in the chat, you couldn't retain people. So you could hire them, but you couldn't retain people. And so that's such a critical component of leadership, is that ability to retain leaders and also ability to retain staff. And so we have to be thinking about these things as well.
Yeah, that retention, and I think An's point also kind of highlights that, like, yeah, it's not easy to bring about that change. Maybe initially you can get that first little bit of a change, but then to really sustain that is really challenging. Great. Well, thank you so much for sharing that. And thank you, Anna. If people have other questions that occur to them as we move forward with the rest of the meeting, please do feel free to put those in the chat. Although, sorry, Megan, I see that there's one more question. So we'll just take time for this last question before we move on. So Megan is wondering about the effects of women taking on the burden of elder care, and curious if anyone has seen strategies to support women through this experience while maintaining a leadership role. And Anna, maybe you didn't see this in your research particularly, but if other people have seen anything that has helped support women through that process, that would be great to hear as well. If not, I will leave that in the chat, and if people have experiences they would like to share, please do respond to Megan's question as well. Okay. So we will be moving on to the panel portion of our meeting at this point, and I will turn it over to Erica to facilitate that panel.
Great, thank you so much, Heather. We wanted to follow up those two really awesome kind of global and more data research-driven presentations with some voices of women leaders who are doing programmatic work across the field. If you go to the next slide, I'll introduce our panelists. We're going to hear from Wendo Sahar, who is the founder and executive director of Dandelion Africa, which is a Kenyan-based women-led NGO focused on women's health and economic empowerment. We're also going to hear from the Nana Girls and Women Empowerment Initiative in Nigeria. We were supposed to be joined today by Fatma Adamu, but due to a very last minute flight rescheduling, she's going to be represented today instead by her colleague, Sadia Khalid. And then we're also going to hear from Sujata Pawar, who's the co-founder of Avni, an Indian-based company specializing in non-toxic menstrual products. So I'm going to ask each of these women leaders a question and give them a few minutes just to answer from their own experience. We'll have a few minutes at the end to follow up with questions. Feel free to also drop some questions in the chat. So next, we're going to start with sort of just asking each panelist to talk a little bit about their own personal journey and leadership story. So Wendo, I'll start with you. Can you spend a few minutes talking to us about this? And if it's possible to take to put on your video just to say hi, that's great. If not, we totally understand bandwidth is a problem. So Wendo, over to you.
Thank you so much, Erica. Can you hear me? Thank you so much. Thank you so much for having me. And yes, I come from rural Kenya and work for a grassroots organization. My leadership journey, wow. When I founded Dandelion Africa with an amazing staff of one 13 years ago, leadership was not something I thought about. I was not born believing that I could lead due to the social structure that I came from. I did not have agency, that's for sure. It took 5 years into the role to grasp the magnitude of what we were creating. At the time, I was dreaming that one day I was going to build a state-of-the-art center of excellence to give dignified healthcare to women from very remote areas, because I work in the arid and semi-arid regions of Kenya. Now, I started to interact with women in leadership, and that was when my awareness was awakened. I audited how I showed up for myself and other women, and that it helped me to understand also what I stood for. I accepted the things that I could not change. For example, I have a big nose, yeah, and I need not to feel insecure about that. I'm soft-spoken, And I was working in a patriarchy society where sometimes I had to send a man to speak on my behalf, because as a woman who had not gone through female circumcision in the community where I work, I was not allowed to speak in front of men. Now, at that point, that was 5 years into founding Dandelion Africa. That was when my actual transformational journey began. It's overwhelming to be a woman and a leader. I think in the context of the village where I work, and in the context of the patriarchy nature of our community. At the time, I was so overwhelmed. I had severe imposter syndrome, and I felt like I was not good enough. I mean, who was I to want to change the world in my small way, in my village? But then I was also so tired of being so lonely, because leadership was proving to be a journey where you are by yourself, sitting somewhere doing your own thing and nobody talking to you. And even then, at that point, I was overwhelmed by the fact that I am an introvert extrovert who could only focus on this one thing, and I was walking on a journey where nobody even understood what I was doing. Now, it took a while, and I decided, you know what, Wendell, why not you? Why not you? I was so scared of talking in front of people. And I did something crazy. And I think that is where, for real, my transformational journey began. I joined a pitch competition and stood in front of 1,500 people to talk about the Boys for Change program that I was dreaming in my head about, how I believed that boys were the reason, as we need to mentor more boys to understand why agency in girls is so important, so that as they grow into men, they can pave way for women to be leaders, because that was the greatest challenge that I had had. And to my surprise, I won. And I felt so good about myself when I went back to my community. Women and girls was like, I really want to be like you, Wendell. Look at the change that is happening in the community. Women are using contraceptives because of the intervention that is working. A lady called Margaret told me that finally all her children were going to school because she was able to have economic power, and because she had used contraceptives for those 5 years. And at that point, I think I realized that I was actually on the right path. And yes, maybe I was not born a leader, but here I was in this position where I could make change in my small way. Now, it's been 9 years since my transformation began, and I lead with authenticity and intention. I am not afraid to lead as female. I come in with all my emotions and compassion. At Dandelion Africa, we have 70 staff, of whom 68% are female. 80% of those are in leadership position with intentionality. We are very intentional about the challenges and the weight women carry, whether in leadership or not, because you're not just a leader or you're not just a worker or a staff. You're also a caregiver at home. You're a wife, you're a mother. We have like menstrual pause days, for example. When we have activities, we ensure that our staff have nannies that come with them to all activities. So I lead with intentionality, and to be honest, I really don't care what people say, because at the end of the day, the more leaders who are women who are in this position think about how they wanted to have been led if it was them. That is the way I show up in my leadership journey. Now, today we serve 1.3 million people, and every year 30,000 women receive contraceptives door to door. I don't know, if I had not said, why not me? I don't know what would have happened to these women. So I continuously hydrate my leadership muscles. I give myself grace. I forgive myself for all the things that I feel insecure about. I show up in my full capacity, and I continue to lift other women and create spaces for them to thrive, because I know that this space I'm sitting on, I would like a woman to sit in this position and many more in future. Thank you so much, Erica.
Thank you, Wendo. I mean, I think we can all resonate with a lot of the things you said, and I, for one, would like to come work for your organization because it sounds amazing. I'm going to ask Sadia if you can share a little bit about, I don't know if you were going to share specifically about Dr. Fatma's experience or your own, but a little bit about Nana.
Yeah, I'm going to share about her. She have given me some write-up to say about her. Hello, everyone. My name, as you have said, is Sadia Khalid. So I'm going to say on behalf of Dr. Fatima, the Executive Director of Nana Girls and Women Empowerment Initiative here in Nigeria, Sokoto. So I'm going to say what she has written for me to say out. So Dr. Fatima said, I am a sociologist. I am neither a health worker nor do I have any medical training. My journey started growing up in my small town and residing in a university environment in northern Nigeria. I am the first child of an extended family. I came from an extended family with about 3 to 4 generations in one family. So you can imagine how bulky it is. And her father and my father happened to be the first child in that extended family. So the leadership started right from home. I've seen a lot of challenges that while growing up in that extended family, there are some section of family that can afford access to good healthcare services, while there are some family section that couldn't afford that good healthcare services. So that is one of the trigger that made me to see how I can how I can help women to have role in leadership. And the second reason is I grew up in the university environment where there was inequality in accessing hospital services. For example, women face discriminatory practices when they visit hospital. The reception and treatment the people face is shaped by how well they dressed and status. Because the university environment is being surrounded by villagers who sold the land to the university. So if, for example, a staff of the university goes to the hospital, a special treatment is being given to that staff. But when a villager that is around that university goes to the same health facility to have access to the services, he will not be attended, or she will not be attended as much as it's supposed to be. So there was that discrimination, that inequality that was not balanced at all. And also, there are some certain examples that when they come to vaccinate children, this measles vaccination, polio vaccination, they only centered around those university staff children, without vaccinating the villagers' children. So at the end of it, the children of the villagers will be dying, while the university staff children are in health condition because they are being vaccinated. So that inequality that I have seen while growing up, it makes me to have a rethink on how can I bring change in what is happening. Then the third reason why I found this organization is there are some wives that do not have voice at all. They do not have voice to demand for healthcare. They do not have voice to demand for any of their rights. So, and this happened because they either cannot afford the services or because of the gender relation that places the responsibility of wife's health on husband. And therefore, the woman need access to healthcare by taking permission from her husband. She doesn't have that right to just access the health facility without her husband permission, because he's the sole care of everything that concerns her health care. So from there, so during that time that I stayed in the university, I was an academician, and I tried to see, at that time I was the associate prof, and I tried to see, okay, maybe if I get myself involved in the government, I can be able to change some things. So I now moved to the government. I became one of the directors in one of the ministries of women affairs. So while I got myself there, I realized that that there is no accountability. That bureaucracy of the government is playing critical role in not allowing women to take leadership. So I had to resign from that government work and now said, okay, what can I do next? So I now sit and say, let me form an organization that can give women and girls voice on either quality education, good healthcare access, people with disability can have equal rights to, and there will be that economical opportunities for women to lay their hands on. So that is all about it.
Thank you so much, Sadia, and thank you for stepping in very last minute to speak for Fatima. Sujata, I'm going to turn it over to you to talk a little bit about your experience founding Avni.
Hello, everyone. It is a pleasure to be part of this group. I see such amazing women in their stories. My journey with Avni actually started with my personal problem. I was just trying to solve for my challenge of rashes and irritation and infections, very recurring ones that I experienced due to the sanitary pads that were available in the Indian market. Most of them are loaded with a lot of toxins and chemicals, and that, as per my research, are also getting absorbed in the body. I could make sense of all this research because of my healthcare background. And what I observed is, if we don't change this, uh, or maybe make some intervention, it is causing long term harm, long term reproductive harm, and affecting the fertility rates, affecting the health, overall health of women, causing hormonal imbalances, and to some large extent also causing different types of cancers. So that is precisely where my journey started. I thought it's a very small problem that I wanted to solve, but if we solve this, it would have long term implications on women's health overall. Luckily, what helped me was, I've seen some conversations before the panel discussion about how supportive family members, parents, your partner can help you get to those leadership positions quite quickly and easily. I think I'm one of the lucky ones in the group to have a father who was extremely supportive. The moment I told him that I wanted to make a sanitary pad, he was like, okay, let's get to it. And, what help do you need from me? He's a chemical engineer working very closely into textiles. So he has actually the expertise to help me, and he did. And the second biggest supporter was my husband, who is also the co-founder of our organization now. He was like, you need to leave your job and do this right away, because it's a brilliant idea, not just from a business point of view. Of course, it's a good business idea because 50% of the population is women, and they are delivering 100% of the human population. So it's a massive thing that we are dealing with. So definitely a good business idea, but there's a larger impact to doing this. So I think without their support, my father's support, my husband's support, I couldn't have started it. Of course, then everybody then else came along. What I realized during the whole journey is, and when we just specifically talk about leadership, my whole experience till date has helped me understand that leadership is, one of the aspects is just all about um, giving out something that a lot of people are not aware of. And that happened, and that is how you build credibility. So I'll just give you some examples. So the in the picture you see our first range of products. These are reusable pads which can be washed and reused. A good 60% of women in India are using reusable products, period products. So this product was an instant hit amongst a lot of the women in India. But surprisingly, the way I started marketing is when the product was ready. I just started making videos with the pad in my hand and just talking about the features and how does it work, how does it absorb, how do you clean it, and all. A lot of the comments that I saw on those videos were about, no, we didn't hear anybody talking about such a product. This kind of information was never accessible to us. We never knew what was being sold to us under the garb of, hygiene and convenience. And there were a lot of toxin and chemicals. We never knew that all of this was existing. Thank you so much for getting this information to us. And that was the moment that sparked a lot of interest in me to keep making more of those videos. Just from my experience, my healthcare background, I was able to put a lot of technical information out in a very simplified and easy to digest manner. And that actually helped us build the whole brand and the infrastructure. Now that we have over 300,000 customers, we sell our products all across the country. So if I had to just summarize my entire story in a couple of lines, it would be this: as long as you can get something valuable out to the community, it can be information, it can be a product, it can be your service, that instantly puts you in a leadership position. And you don't really have to be too educated for that. It's just things that you know and the other people don't know. If you start just by sharing those, it instantly makes a connect and makes you a person of authority. Thank you very much.
Thank you so much, Sujata. This is three very different and inspirational stories, and I'm eager to hear more. I do want to be conscious of time. So the two other questions that we had asked panelists to think about were how your experiences have shaped the programs you lead, which I think you have all touched on a little bit, although I'll give you a chance to go back to those two. And then the third question we wanted to hear about was what you're doing to support other women leaders in health, and that could be through your own organizations or through other things that you do. So I'm going to leave it to each of you to decide which elements you want to focus on, and probably we'll just do one more round of responses and then save a little bit of time for some final Q&A before our last presentation. So Wendo, I'll come back around to you in just a few minutes. Are there more things you would want to say either about how your leadership has really influenced your programs, or how you're supporting other women leaders in health?
Yeah, sure. Thank you so much, Erica. I think for us, the greatest currency we found that women don't have is time, because of the weight of all the things that they have to do. And it doesn't matter whether you're a woman in a rural community in Kenya or you're Erica sitting somewhere in an office. The greatest currency that we don't have is time. There's just so much to do and so many expectations of us. So for us, I think one of the things that I have tried is to lead with intention, and always asking myself why. Why is it that the women who work so hard are the ones who are the most poor? Why is it that you can find a soft drink in the most remote part of Kenya, but you can't find a basic need or a basic commodity like contraceptive or water? And trying to answer that from a perspective of a woman who has carried water on her head, who has walked without shoes. I want to understand what's going on and then trying to solve and get to the root cause of those issues. But I feel like our programming has evolved in asking those whys. That is why we are able to focus on agency of women by providing contraceptives door to door in the most remote places where hospitals are 20, 30 kilometers away. I really care about women and money, because I have seen in rural communities where when a woman doesn't have money, she will not have health much longer, and vice versa. So in our livelihood program, our women livelihood program, looking at economic power of women and how use of contraceptives actually, they're intermarried, because when a woman has time for productive work, she actually puts the energy into looking for money or finding money or keeping money or whichever way. But most importantly, she has the agency then to vie for leadership positions and is able to change how things work in the society, especially sometimes through our advocacy program, where we engage them in dialogues with our members of parliament and members of county assembly. So I feel like that is how we have our platform. I'll briefly touch on the last part about how we support women in health. For us, recently we launched our Women in Leadership Council program. And this is because we've noticed that a lot of women who are in leadership in health are going through something. There is a chronic mental health gap within the system, in our country anyway. So how do we ensure that we are looking out for women and making sure that there is self-care, there is wellness programs for them, and intentional about it, such that when we have programs where we are taking them somewhere, they bring along their nannies. Because the thing, you don't go because you're leaving your child with someone, so you have a small baby, so I'm not going. How do we make sure that we have all those things in place? The other thing that we are intentionally doing is having a men-only forum, because I think that we are constantly speaking to the choir, but the people sitting in power, I don't want to sound like that, but in essence, we have to be able to speak to the current power there is, to be able to make sure that they are aware about the choices that they are making and how issues like sexual violence is actually inhibiting women from vying for leadership positions or even advancing, especially in the healthcare sector. Lastly, we are coaching women to normalize being in leadership and to create spaces for other women to lead. And I think sometimes that is our greatest challenge, especially in the healthcare sector. So yeah, I'll finish there, Erica, for the interest of time, and thank you so much.
Thank you, Wendo. And yes, I mean, I always notice, who joins the meetings, and we do have some fabulous men on the call today, but we often do preach to the choir a lot. So how to broaden that conversation is really important. Okay, I'm going to ask Sujata, do you want to jump in with some other thoughts on how you're supporting women leaders? And then we'll end with the Nana Girls example.
Yes. So I'll quickly talk about one of the initiatives that we recently started to just empower women with healthcare knowledge. And these women are not trained in healthcare, but just because we don't have access to so many healthcare workers in the remote areas in India, we are trying to create a force and train them. So what we are trying to do is we have identified different locations across, say, a particular state in the country. We are identifying women who are either school teachers, so who have the authority of training and credibility to train about healthcare stuff, or the local doctor or the physician who is there. So we approach them, we train them on basic menstrual health awareness. That's a small protocol that we have set. We train them on those modules, and we also train them on our products. And then these women then go and talk to their communities about the same modules, educating them on menstrual health and intimate health, and also talking to them about the products. They also carry products along with them. So in a way, they are also working as our channel partners, but we are taking the approach of education plus sales. That is how we are trying to impart some good amount of awareness in the rural areas of India, and also make these women a little more financially empowered, because they are trying to earn some good amount of commissions through the product sales that they make. So this is an alternate channel. It's a sales channel for us that we are building, but it's extremely high impact, in a way that it is definitely empowering the woman, the trainer, with money and knowledge, but she's also then going on and impacting as least as 100 families in different villages. um, uh, so that impact actually resonates to a good 1,000 people in a village. So that is how we are trying to build this network.
Thank you, Sujata. That has the potential for huge impact. I love it. Sadia, last thoughts from your organization?
Yes, so for Nana, okay, let me start with the support we give to other women in women leaders in health. At Nana, we provide scholarship opportunities to girls from disadvantaged background so that they can take up medical profession. For example, the community health extension workers, we do give scholarship to less privileged girls. We support also nurses, community nurses and community midwifery by offering them the same scholarship to see how, like, to support them so that they graduate to become the community nurses. We also strengthen the capacity of women-led community-based organizations. We train them on how to manage their funds and also how to deliver projects in a sustainable and equitable manner. Also, at Nana, we give women, girls, opportunity to be trained. We mentor them and encourage them on how to apply to a bigger organization if they wish so. So we also try to see how we can mainstream Jersey in every of our projects. For example, we consistently ask the question, would women and other vulnerable groups come out of the project in a better position? Are we creating another problem by solving another one? So we do some of these things to see how we can support the women and girls in our society. Thank you.
Thank you very much, Sadia. I think we are going to pause here. We have a few minutes at the end of our webinar for more Q&A and discussion, and I really encourage you to put some questions in the chat too, if you have specific questions for these three amazing panelists. Thank you so much for sharing your experiences with us. And I think that we've really generated some interest here, and I bet some of you are going to hear from other folks on the call about, further discussion. We're going to end our series of speakers with a presentation from Dr. Jacqueline Kitulu. And Heather, I don't know if you had planned an introduction of Dr. Kitulu, or I can just pass it over to her if she's ready.
No, yep, please go ahead and pass it over.
Okay. We are joined now by Dr. Jacqueline Kitulu, who is the president-elect of the World Medical Association for the coming year. And she's also an alumni of the Women Lift Health East Africa network. So Dr. Kitulu is going to just share some thoughts with us about her experience in these leadership positions. Dr. Kitulu, I'll turn it over to you.
Thank you, Erica. Good evening, everyone. It's a real pleasure to be here. Unfortunately, I wasn't able to hear most of the other presentations, but I'm glad I'm now finally here. So I am indeed, as Erica has introduced me, I'm the president-elect of the World Medical Association, but I am also a practicing family physician. So yes, my day job is I see patients. A little bit about my background. I got into leadership almost by accident. I went to a Kenya Medical Women's Association meeting, and they were trying to look for people to step into leadership positions, and I volunteered, and the rest is really history, because after I stepped in and volunteered to be assistant treasurer, I then a couple of years later, I was elected as the chair of the Kenya Medical Women's Association, where I served for 2 terms between 2008 and 2012, and in which time I got to be into more leadership positions because I was nominated then to sit within the President's Advisory, our national president, the Kenyan President's Advisory Committee. It was called the National Economic and Social Council, a committee in which there were 43 members and were only 3 females in there. So it was quite an uphill task. And subsequently, I got poached back into the National Umbrella Association, which is the Kenya Medical Association, where they were looking for diversity within their leadership. They had just basically a totally male committee, and I got in there. But from 2016, I was elected as the first female president of the Kenya Medical Association. And that was in its 48th year that I was the first female. So, I mean, leading from there, of course, I've ended up sitting in several boards and within like our National Hospital Insurance Fund, within our regulator, the Kenya Medical Practitioners and Dentists Council, which regulates medical practice in Kenya, and several other private sector boards. And yes, and then finally, fast forward to October 2019, I then stood for election for president of the World Medical Association. And yes, I was elected and got through from, with a clear majority. I got 100 votes against 24 votes of my contender, who was male, older, and which is the face of the World Medical Association, older males. So I just give that context just so that even as we look as women in leadership, just to see what the journeys may look like. And within all those journeys, a lot of it for me has been more of volunteering my time. And I've served in places where I thought, I'm not going to sit back and complain. I will step into the space and try and be the change that I want to see in that place. And for women stepping into points of leadership, you'll find, yes, it's a very isolated area. Even in the World Medical Association, where now I'm president-elect, it's been 75 years of existence. So that means they're so I'll be inaugurated the 76th president. But in those 75 years, there have been 70 males. I'll only be the 6th female and only the second African one, second African female. So there are many challenges. And so to my presentation then today, where I have no slides, I'm sure you have seen very many, and I said, I think I'll just talk through it. And what I want to talk through is about a program called Women Lift Health, a program that is really set out to increase women's leadership in global health. So I am an alumni of the program. I am part of the inaugural East African cohort, that's a 2022. And in those many years of leadership that I've gone through, I've done many leadership programs, but this was absolutely amazing in terms of how focused it is on women in particular in leadership. So Women Lift Health's mission, basically, it has a vision to have a world where diverse, accomplished leaders collectively transform global health outcomes. And its mission is to therefore expand the power and influence of talented women in global health and catalyze systemic changes to achieve gender equality in leadership. So it has been tailored specifically and has a total mission of just getting women up into senior leadership. And the theory of change of this, this program is that there's an individual aspect. It has to target you, the female, as an individual, then target institutions, and then finally society. And basically that what then you'll have as an outcome of targeting the individual, the institution, and society is that within the individual, you build the women's confidence, their skills, their networks. Then you can have women influencing teams and institutions, women expanding their visibility and voice, and then finally allies supporting an enabling environment in society. Medium term, what do you expect? That maybe women leaders expand their power and influence to lift themselves and elevate others. On a long-term basis, that you'll have women leaders transforming health practices and policies and reimagining health leadership at scale. And the ultimate vision really then at the end is that you have improved health and gender equality. So who are targeted in this program? Again, it's mid-career women who are already in some form of leadership in health. There are certain provisos that, yes, you must identify as a woman. And then number two, that you're mid-career, at least you've had 10 to 20 years of experience in public health or global health, a place where you have a focus, whether it's in practice or it's in policy or research, because those are the levels at which we have very few women in leadership and making change. So that's who it targets. And what then is, why the mid-career women? Because one, they're at the stage where women face the toughest bottleneck. So, the lower levels of within the health sector, you find actually it's a majority of women. But as you move up to the middle level, to the senior level, then that's where the challenges arise. And once women reach middle level, that's where there's the toughest bottleneck to getting to the next level, which is the senior leadership. And that's where most women then will risk opting out or being pushed out of the leadership path. So number two, the women in mid-career women also face tremendous barriers, but without any meaningful opportunities for leadership or skill enhancement. And those are things like coaching and mentorship. And those are things which really can leapfrog them from that point into senior leadership. Also, mid-career women are targeted because indeed they have amassed a wealth of knowledge, expertise, and networks, which they could and should leverage for the betterment of vulnerable communities and whom they wish to serve. And finally, these mid-career women are targeted because they can reimagine and shape the next generation of the leadership of the future. So that's in terms of who is targeted. For an example, I'll just give, because from within the East African area, what are some of the top barriers in the workplace? And this is from studies which have been done by Women Lift Health. And interesting, in East Africa, the number one barrier, which 56% of the participants answered, was harmonizing their personal responsibilities with work. And I think it's not too different for women anywhere. And 2 was gender discrimination or harassment in a male-centric culture. And 3 was navigating workplace politics or interpersonal relationships. And there are many other things that follow that, but those were like the top 3 that came out. So even as I mentioned this, there are many cross-cutting barriers which women in leadership will face, and is partly what this program aims to target and help women work through. So of course there's the gender stereotypes that women are default caretakers, and yet so in their homes they have to deal with that, and yet they have to balance that with their professional responsibility. 2, there's the imposter syndrome, where internalized sexism leads to a lack of self-confidence for women and attributing success to factors such as luck instead of women's capability. So imposter syndrome is number 2 as a cross-cutting barrier. Number 3, there's the old boys networks. So historically, male-dominated health sector often keeps women, especially women of color, or minorities, out of the leadership positions. 4, there are limited mentors. Indeed, there's a lack of senior women mentors and role models, which limits women's ambitions. Indeed, in many of the places I stood, like in the Kenya Medical Kenya Medical Association, I was the first female president. And that's a place where, indeed, you hadn't seen any other female in that position. So what drives you to step there? What pushes someone, who can you ask? How do I navigate this territory? The other cross-cutting barrier was gaps in legal protection. Indeed, women still face gender-based discrimination compared to male peers. And mobility and safety, that of course there are safety concerns and challenges with work-life balance during travel, especially for women who are like in grassroots areas in India or in East Africa. Those are real cross-cutting barriers that women have to contend with. So in this program, then this leadership journey, so Women Lift Health has a 12-month leadership journey, which focuses, again, as I said, those mid to senior career women, and aims to give them tools along with peer, mentor, and coaching support to successfully amplify their voice, expertise, and leadership for impact. So the program has like 4 pillars, and pillar number 1 is authentic leadership. Essentially, it is more of very internal. You have to establish, to discover, in other words, discover you as the leader. What is your, to explore your identity, how to lead with purpose, how to fuel your resilience. So it's really a lot of discovery of the self. And then the second pillar is on inclusive leadership. So enriching your mindset, strengthening your voice, developing allies, male allies, especially amplifying the voice. Then to pillar number 3, which is strategic leadership, which then is to inspire action, to leverage our power, and to lead change. And then the 4th pillar, which is the final one, because all leadership must come to something, and it's impactful leadership. They're developing leaders who are able to lift up and transform, the lead, whichever sector in which they will lead. So those are the main pillars of of the Women Lift Health program. So how has this program run? It has run all the way from about 2021, 22. So from 2020, it has been able to establish partnerships and platforms for scaling. So far, they've worked with over 290 women leaders, engagement with now about 140 alumni. It's taking actions and making changes. So about 50% of the women are contributing to changing health policies. A quarter of the first Indian cohort are working with Women Lift Health to bring leadership learning to community health workers. There's 70% of the alumni have reported increased responsibility. 88% have said they've had increased budgets in areas where they lead, and even increased staff with where they are going. So the program aims to reach and to have, at the moment has over 254 online. If you're looking at impact from social media, which yes, nowadays you have to look at that as well. It has over 944 million mentions, meaning that's the subject is getting out there. So yeah, that's a little bit about the Women Lift Health program. I think I was to speak and then allow for some interaction. So I think I'll stop there. Erica, back to you.
Thank you so much, Dr. Kitulu. It sounds like an incredible program, and I know that you've taken a lot from it, and I know we have other colleagues on the call who have participated as well. And congratulations on your coming leadership year. That's fabulous news for everybody. I'm going to suggest that we move to a general discussion time that we can include both questions directly to Dr. Kitulu, to any remaining questions from the panelists, or some broader questions that we wanted everyone to think about in terms of bringing this conversation back to SBC in particular, and how specific SBC approaches and strategies could be used to address the factors that we've identified today that affect women's health leadership. Or if people just want to share other programmatic efforts that have been impactful, we can really use this last 10 minutes or so as overall discussion or ongoing clarification for questions for other presenters. So I'll open it up, or if there are questions in the chat, I am happy to try to sort through those as well. I appreciated Carol's comment in the chat to get a male perspective in here, and to see this, as this is as a space for growth and innovation for women and men. Of course, it's this is not just about women, but it should be a space for freedom of sharing and caring and developing and building accountability structures. I really appreciated that comment. So thank you, Carol, for sharing that. If anybody wants to just come off mute and make comments or questions, that's fine.
I actually have a question. It's not specifically related to either of these topics, but we did some research in Kenya earlier this year where we were looking at health worker leadership and performance. And one of the questions we asked was about the impact of gender. And most of the respondents were women. There were a few men, but they all said that gender wasn't an issue in their work, really. They mentioned a couple of examples not specific to the health system, like maybe women not wanting men to do pap smears or something like that. But I found that really interesting, and I'm wondering if Dr. Kitulu in particular, or anyone else wants to can speak to that.
So that's interesting. So the questions were to who? To the healthcare workers, or?
We asked health workers, specifically health workers who are vaccinators. We asked their Kenya, what do you call them? Facility managers, whatever that's called in Kenya. I work across several countries, sorry. And the sub-county and county MOH and EPI, which would be the health management teams, I guess.
Sorry. So indeed, when you're sorry. So indeed, the context indeed matters, because if you're talking about vaccinators, and most of the times those working in EPI will deal with children. So there is really not much of an issue that will step up there. But step into the hospital setting, step into the clinic setting, and begin to deliver care, then you begin to notice some of those differences. When I was an intern in the hospital, even the patients will refer to you, because you're female, they refer to you as a nurse instantly. It doesn't matter that you're wearing your coat, you're wearing a label that says your doctor so and so, you're the nurse. And they're like, okay, so where is the doctor? Even in terms of, even when you're giving certain feedback, they're looking for the stereotype, who's meant to be the one who's to give me such information, someone older, a male figure. So there is that aspect even in just healthcare delivery. But even when you get into the leadership and you're just going into the managers and moving at higher levels, you'll find that women just drop off. They drop out of the system, again, because of that initial barrier. How do you juggle everything that you're doing? So you have then more and more males at that higher level. And as the women try to get into that level, people are also hesitant. And they look at a young woman and she might be asking for maternity leave. And do we really want to have her in place between her and a male? All those little things that are, those microaggressions, they're all there constantly. So, and sometimes, you can also live in an environment where that's what you've always seen. So you count it as normal. It isn't. And we need to speak out to it. Thanks.
Thank you.
I have one question. I'm just curious, anybody who has presented or been on the panel today, I would love to hear your thoughts. Several of you have raised points about, kind of male allyship and also involving men in this. And I'm wondering if you have any thoughts about the balance that needs to be, taken here, because we don't want to push more male misogyny or whatever it is. But we also know that I can't remember who said it, but we can't just keep speaking in a vacuum and preaching to the choir. We do need to involve them in some way. So I don't know if people have ways that they have seen or used to find that balance between those two. And maybe, Anna, you were mentioning some research and work that's been done at the Carey School that maybe you could describe a little bit, but I would love to hear people's thoughts on how we approach that balance.
Yeah, I'd be happy to jump in a little bit with what I know of the work from both Carey Business School and Equimundo. And a lot of their work has really focused on the ways in which allyship can start at home for a lot of men. So fostering, it can sound kind of terrible, but fostering this idea that like women are people too, really starts at home, seeing it in terms of enhancing equity with work in the home. That labor at home then translates to work, right? It's kind of like if you can personalize the people in your life, then it's easier to personalize the people in your work. And so a lot of the interventions that have been successful have been around focusing on equity in the home. And I think this also speaks, though, to so many issues that we see in the workplace, right? Around childcare or elder care, or this idea of maternity leave. I mean, what if people said, oh, he's about to be a father, do we want to give him paternity leave, right? If it's the same, if we're looking at people holistically as caregivers, as people who have home responsibilities, that's where that allyship can really be fostered. And so much of that research is really pointing towards that, like start at home, don't start at work.
Just a quick one for me. I posted it. Is there any work you can share how women leaders promote other women? For example, I'm giving an example. Even for family planning, anything, mother-in-laws are more upfront opposing helping their daughter-in-laws instead of the father-in-law. So what is it? We are majority 51% women and 49% men. Still, we are talking about system, men allyship, and how about women? Are they intentional when they are a position helping other women?
So let me jump in there and go on to what Anna said about personalizing. I mean, on the point of male allyship. And I mean, for me, I keep on saying in wherever I speak that my husband has been my male ally number one. In the sense that in the sense that even when my children were much younger, and again, these are the traditional roles we expect women to do. You know, you're the one who, the mom is the one who goes to the school meetings, the one who's in the Parents Teachers Association. My husband did all those things, and not because he's not a professional, he's a lawyer, but he did those things because I was in leadership positions that took me away and I had to travel and I couldn't be present. But it starts right there that, you know, that yes, someone does appreciate that, yeah, it is okay for him to do that role. But again, in all the places that I have actually then ended up in leadership, I have literally been sponsored by men. And that's not to say that women, you know, there's that myth that women are their own worst enemies. No, not in that context. It's in the context is that they were the ones who were in the space. There were no women in that space to sponsor me or speak for me in that room and get me onto that table. They were the ones who were in the space that I was working. So, and when you work with males who then appreciate the diversity that women bring into a space, it begins to roll. So when I got into the Kenya Medical Association, I was the only female on the national executive. At the point when I left, and even now, we're on the second president after me. Right now, that executive has a majority of women. It's an executive of 6. There are 4 women, there's 2 men. And coming from a point where I was the only woman. So the males who have subsequently stood in leadership have appreciated the women will do this better. It is okay to have women because they do deliver on the promise. So it's and that's why these conversations have to involve the males. We are all there in the environment, and the idea is not to women to take over from the men, but that we can all bring in and have a more inclusive kind of leadership pattern that leverages on what we do best, you know, from our different viewpoints. Yeah, so I think that's what I would have to say about male allyship.
Thank you so much. This has been just one of the most, I think, engaging and interesting webinars I've been to in quite a while. And thanks for all of the comments from all the participants. In the interest of time, I think we're going to have to move to wrapping up, but we will be sharing the recording and some notes. So I encourage you all to get in touch with others and keep the conversation going. Heather, I'll turn it to you for the final thoughts.
Great. Well, thank you again to all of our presenters and panelists. It has been a wonderful discussion. Thank you for sharing your time. Some of you very late in the evening. So thank you so much for being here, and thank everybody for their participation today. As Erica said, we will share the recording as well as the meeting notes in the upcoming days. And as I said earlier, we will share additional information about the transition of the co-chair to Inspire SBC. And we hope that you all have a great rest of your day. Thank you so much for joining. Bye.
Thanks, Heather, and thanks for your leadership of this community.
Bye-bye.
Thanks, everyone. Take care. Bye.
Bye.
No.